Hello, my name is Dr. Rainer Hochgatterer. I'm an orthopedic surgeon, sports medicine specialist and knee specialist in Linz in Austria. In today's operation, we are going to fix an unstable patella with an MPFL plastic. The transplant is going to be fixed with the shark screw tendon and 100% allogenic human bone screw.
The case presented concerns a 14-year-old patient with recurrent patellar dislocation in the left knee. He suffers from pain and significant instability in the knee joint. For the reconstruction of the ligament apparatus, an autologous gracilis tendon in combination with 3 shark screw tendons is utilized. The 100% natural graft provides the young patient with numerous advantages. For the MPFL reconstruction, the patient is positioned in a supine position. The leg is freely movable. At the start of the procedure, we establish anterolateral and anteromedial portals for arthroscopy. A diagnostic tour of the joint follows. In this patient, the suprapatellar recess is normal, but there is a noticeable laceration of the patella. Additionally, the trochlea is somewhat flatter with a small cartilage flap, which is resected. The cruciate ligaments, as well as the medial and lateral compartments, show no abnormalities. To harvest the gracilis tendon, an oblique skin incision is made in the area of the pes anserinus. After opening the skin, the gracilis tendon is looped and easily retrieved with a stripper. The graft measures approximately 25 centimeters in length and is looped at both ends to 1.5 centimeters using a 70 centimeter long Vicro suture and is then preserved in vancomycin. Next, a medial skin incision is made in the area of the patella. The patellar periosteum is approached directly, pre-prepared in the appropriate layer extra-articulary towards the medial epicondyle. By using fluoroscopy, 2 long 1.8 mm K-wires are inserted slightly converging and ascending ventrally approximately 2 centimeters apart, penetrating the cortical bone of the patella ventrally. Subsequently, a blind hole is drilled through the cortex using a cannulated 5 mm drill bit. These drill holes are intended for the tendon ends of the graft. One end of the graft is then pulled into the cranial canal and the other into the distal drill hole. The tendon is initially secured in this position with a vancomycin swab. A skin incision is made in the area of the epicondyle in the next step. In an exact lateral X-ray view, the entry point for the femoral drilling is chosen to be slightly ventral to the intersection point of the Blumenstadt line and the dorsal cortical line. The femur is then pierced at this point with a 2.4 mm guide wire, as well as through the opposite cortex and through the skin. The blind hole is over-drilled with a 5 mm drill. Subsequently, a shuttle suture is passed through the femoral canal, and the graft is pulled through. It is crucial to ensure that the strands of the graft do not cross during this process. To maximize medialization of the patella, with the knee extended, maximal tension is applied to the suture holding the graft in the middle of the femoral canal. The knee is then gently moved multiple times, and the tension on the suture is loosened enough for the patella to self-center. The patella is now well stabilized, with no tendency for luxation and not too tight. In the next step, the tendon is fixed to the femur with a 5 mm shark screw tendon. Only then are the sutures used removed, and the wound is closed layer by layer. The reconstruction is reassessed arthroscopically. The movement of the patella is completely centered, not too tight, and freely movable. Subsequently, the irrigation fluid is drained, a local infiltration analgesia is performed at all surgical sites, and a knee joint orthosis is applied. The X-rays show the post-operative result. The knee joint arthrosis is adjusted as follows: 2 weeks at 30 degrees, 2 weeks at 60 degrees, and 2 weeks at 90 degrees. As part of physiotherapy, the knee can be moved with passive assistance without a brace up to the pain threshold. With the help of the surgery and post-operative physiotherapy, the patient once again has a completely stable knee joint and can pursue his hobbies pain-free.